Those were beautiful examples, Libby. Our next speaker is Dr. Laura Olivieri, and she is professor of pediatrics at the University of Pittsburgh School of Medicine, and she is director of the non-imaging section here in the Heart Institute at Children's Hospital of Pittsburgh. And Laura will be talking about preoperative imaging, MRI and CT, strategic advanced imaging. Thank you, Laura.
Thank you. And thanks so much for inviting me to be part of this special conference. I appreciate it. So we are going to talk about, we're going to briefly step through the imaging modalities just so we can understand what our options are for advanced imaging. We'll review some guidelines that are salient in the space, and then we'll review some cases. So I think what first comes to everyone's mind usually when we think about cross-sectional or advanced imaging in this in aortic valve disease is CT. CT exquisitely demonstrates the arch anatomy, thoracic size, the thoracic aortic size and morphology. It's extremely high resolution. You can assess really any part of the aortic arch is accessible by CT. Not many limitations there at all. And then we can create these 3D reconstructions, which can help both with decision making about what treatment a patient needs, and then if surgery is selected as the treatment, can help plan the operation. As we know, CT pretty much always involves contrast exposure, always involves radiation exposure. And then for smaller children, if CT is selected as your cross-sectional modality, you may need sedation and may actually need a sedation strategy that involves cessation of respiration, so potentially general anesthesia. And then people of any age, depending on how you're going to image, may need a heart rate lowering strategy. And this, I'm going to spend a couple minutes on this slide. This is part of the strategy here, I think, is understanding the risk and benefit of how you're going to image, what you need about what information you need beyond echo for your patient, and then how you're going to pay for that. I'm not talking about dollars pay. I'm talking about exposures to your patient. And it's hard to summarize this all in one slide or a few bullet points, because the fact of the matter is now there has been kind of a, for lack of a better phrase, disruptive technology change in CT with the advent of photon counting CT scanners, which have greatly reduced CT dose and given us incredible capability to get these really exquisite pictures and not really cost a lot of radiation at all. And so now out for all of us listening to this, there's a wide range of CT scanners that are available. So when you think about imaging strategically, if you're imaging on, as we were about a year and a half ago, imaging on a 64-channel CT scanner that would have required 4 or 6 heartbeats worth of data to get a nice gated CTA of the chest, that's the kind of this radiation exposure and the anesthesia sedation route for that kind of imaging is totally different than a newer generation scanner or photon counting scanner, where those images happen so quickly, can really minimize cardiac motion, even without gating, but I would always recommend gating. You can really minimize cardiac motion and get a still shot of the root in a little bit. My colleagues here, Adam and David, are doing this in a radiation dose that approximates a chest X-ray. So there's a wide variety of tools available, and there's a wide variety of strategies available. If anyone ever wants to talk CT strategy, we're happy to do it. And we look forward to learning from those of you who have great strategies at your institutions. But suffice to say, there's actually a lot here, and I'm happy to chat more if people have questions about it during the panel. But the overall goal is to, using the gentlest imaging strategy possible, get a really pristine and measurable picture of the aortic root, subaortic region, and then ascending aorta. So moving on to other modalities, we obviously have MR. We all love MR as a cross-sectional imaging modality because it can give you all the pretty much all the anatomic information that a CT can, but then also gives you information regarding LV size, mass, thickness, LV function, and then more information about flow dynamics in the left ventricular outflow tract, and I'll show you some advantages of this. There's obviously no ionizing radiation exposure. I often, with our scanner here, don't tend to use too much contrast in LVOT cases, but some may require contrast. And depending on the length of the exam and how much information is needed, may require sedation to get this done. And then I would put like TEE. Sometimes I think of this as an advanced imaging modality. This is covered beautifully by Dr. Lanford. But certainly I think a lot of additional information that can be gathered here when you're thinking about aortic valve, aortic root, surgical issues is like leaflet morphology, coaptation defects, just like Dr. Lanford beautifully pointed out. And this is especially salient if there's operative disease and surgeons are thinking about repairing, which is an unusual circumstance, but if you're in that circumstance, this is the modality you want. Okay, so just like briefly to be aware of, I'm sure we all are aware of, but just to remind us all about some of the guidelines of this space. So this is the valve management guideline that talks about when it's appropriate to manage or replace or surgically address aortic root dilation. So the one number to keep in our minds is cross-sectional imagers, and the thing we're looking for with cross-sectional imaging is an accurate root measurement. And so if it's greater than 5.5, you sign that patient up for some operative, appropriately sign that patient up for some operative management of their aortic root. And then if there are other risk factors or other genetic predisposing kind of conditions that would make that a higher risk aortic root, the number falls from there, 5 and 4.5. This is just from this guideline. Shane Morris and her group just put this guideline out last year. This is fantastic. If you haven't read it, it's worth reading and then keeping around for reference. We're mostly, and during this session, we're mostly talking about information down at the bottom of the slide with bicuspid aortic valve, prior ROS, et cetera. And so there are thresholds for kind of standard risk and high risk when to operate on the aortic root. So that's why we do this, is to understand, we really need an accurate measurement of that root and of the other aortic structures. And for kids in the pediatric range, we don't just want a size, we want a Z-score. It's also helpful. I think Diane put beautiful pictures up of the kind of the correlation between the past specimens and these high-resolution CT images. We can give the height, the distance between what we think of as the valve annulus and then the aortic ostia. We can also describe the location and proximal course of the coronary, the coronary ostia, and then the location and proximal course of the coronary ostia. I don't know so much about our ability to understand leaflet morphology from CT. I think it's getting there. I think some centers do it beautifully. I think further technology development will result in consistency for all of us to be able to do that. And then there are these other like kind of surgical planning considerations, other things you can get from CT looking for, like little ASDs or VSDs, venous anomalies that might affect cannulation strategy. And then looking like for some of these cases, like how far up the arch does a surgical treatment need to carry from the valve. So now just a few cases to go through. This is a patient, let's see. Okay. So this is an old patient, relatively old 20-year-old patient who was born with a bicuspid aortic valve, had several balloon valvuloplasties as an infant and as a young child, had actually had an aortic valve repair in mid-adolescence that was accompanied by an ascending aortic replacement. So the root of this child had not been touched. The ascending aorta had been plastied, and then the valve had been plastied. And he shows up, you can see the thickened, like clearly previously operated on leaflets here. And you don't get quite a sense, but you're starting to get a little bit of a sense of significant aortic insufficiency by the transthoracic echo, which ended up being actually moderate to severe insufficiency. This is this young man's CTA, where you can see kind of that thickened wall appearance where the previous ascending aortic the material to treat the previous ascending aortic pathology had been seen. But then you can also see there's normal coronary origins and a normal aortic root. This is a TEE from his preoperative study where you can really see a wide swath of aortic insufficiency coming through that previously operated on aortic valve. You can also appreciate the significant LV dilation on the CT as well. He underwent a RAS procedure with a really nice result. So here you can start to see what's now we refer to as the neo-aortic valve with no flow acceleration and no aortic valve insufficiency. And then here's the picture of the conduit that again shows normal velocity and no pulmonary insufficiency, neopulmonary insufficiency. A second case is that of a 4-year-old, similar to a lot of the other cases that have been presented, has kind of a history of LVOT issues. He had had a coarctation with arch augmentation closer to the neonatal period and had been followed pretty closely and now presents with at least moderate subaortic stenosis. And it's interesting, similar to the case Dr. Lamford presented, this child had had like a totally clear LVOT as a neonate, an infant, and then this is more recently acquired in kind of toddlerhood in the preschool age group, this fibromuscular stenosis that can be seen here. It's interesting. I totally agree with the point Dr. Lamford completely made beautifully that this subaortic transthoracic image tipped up, like dot at 6 tipped up to the LVOT really is the best place to elucidate this because this isn't so easy to see from parasternal views. Because of the complexity of the child's heart disease, they underwent a cardiac MRI so we could help parse out some of the complexity of the LVOT, aortic valve, supravalvular region, and then get 3D data of the entire thoracic aorta. So you can see these are just regular cines of the LV where you can see a mildly hypertrophied left ventricle. You can see flow acceleration, that little flame of phase dispersion that starts clearly below the aortic valve. You can see it in short axis and you can see it in long axis here. And then this is with some 40 flow kind of superimposed upon the cine where you can see this red flow acceleration starting below the aortic valve. Not a lot of AI, in fact, almost no AI, which is nice, but definitely fibromuscular subaortic stenosis with LVH. And this is part of the contrast-infused aortic angiogram that we performed, and it's subtle. And again, I think to both Diane Spicer and Dr. Lamford's point, the sinotubular junction is, I guess what I've learned in my career is that the sinotubular junction is tricky, and even subtle indentations or subtle, stenosis or narrowing can have big hemodynamic implications. And so this child went to the operating room and actually went resection of the fibromuscular subaortic stenosis and also had some patch enlargement of his sinotubular junction and ascending aorta. And these are his preoperative images where you can see his subaortic region now looks pristine. It's beautiful. His aortic valve looks beautiful, moving perfectly. And I'll tell you, there was normal velocity, no insufficiency on his post-op study. And then here you can see this kind of patched area where the root just leads into the ascending aorta in a nice wide and normal dimension path. The next case is an even younger baby. This is a baby that I'll just start out by saying has Williams syndrome, and so has supravalvular aortic stenosis. Again, to the point that the supravalvular region is kind of difficult to detect stenosis here with like apical and parasternal standard views. You can see here this LVOT looks totally fine. It is not totally fine, but it looks like normal up to the point of the sinotubular junction. And here our sonographer really focused and moved up on the chest to really clearly demonstrate the supravalvular narrowing at the STJ along with flow acceleration. And just more transthoracic images. because I think it's good to see what a heart looks like on echo, and then I'll show it to you what it looks like on CT. So again, the sonographer has now moved up almost into the suprasternal notch area. You can see this like very well-formed aortic valve, very well-formed aortic root, and then all of the pathology at the STJ with severe gradient. This child underwent a CT to kind of further look at the dimensions of the thoracic aorta, as well as look at the coronary artery origins. So I'm going to show this to you in the coronal view. You can see this, because this is a baby, sometimes we gate imaging at above certain heart rates. We actually gate the imaging not in diastole, but in systole, because the more still part of the cardiac cycle is kind of theoretically in systole beyond a certain heart rate. I think the sinotubular junction narrowing is really apparent in this case. Well, I'll let it play through one more time. So you can see LV, that's systolic phase. There's a normal, beautiful normal root, and abnormal STJ, and normal ascending and transverse aorta. So this child, the child also, you probably noticed, also had significant RPA stenosis as well. So this child underwent aortic augmentation at the STJ, at the right non-coronary cusp, and then also had the branch PAs addressed with some aortic valve repair as well. So this is his postoperative imaging. This is not the same, but a similar view, kind of a high arch view where you can actually, it's an interesting view where you can see almost the entire aorta all the way down to the aortic valve. You can see the patch, some of the patch material here. Some of this patch material belongs to the RPA, but there's also some patch material that belongs more to the STJ and ascending aorta. You can see there's no flow acceleration. This is a really nice repair. Okay, final case I'll show you. This is more garden variety, I guess you could say. This is a 16-year-old boy who's not had anything, who has been followed his whole life by a cardiologist, but has not required any interventions up till now. He's a child with, or a young man with a unicuspid aortic valve with a severe aortic stenosis, and then as you can see, significantly enlarged ascending aorta. And this is a case where cross-sectional imaging, I think, is very helpful. I'll just show you that the peak gradient through the aortic valve was 85 to 90. You can see there's a lot of dilation of the ascending aorta leading up almost into the transverse arch with a lot of flow acceleration. No coarctation or anything like that. All the pathology was more focused towards the valve. So he underwent a cardiac MRI, again, to evaluate his LV mass, LV size, LV function, and then the thoracic aortic dimension. So here is just a cine image where you can see, I mean, similar to what we see in echo, we see the same thing in MR when there's a bicuspid aortic valve, or in this case, a unicuspid aortic valve. You can see like eccentric opening when you slice the heart and lung axis. And then we have a kind of an angiogram or a 3D reformat of this child. This child actually did not get contrast. This is non-contrast angiogram, which demonstrates the severely dilated ascending aorta. And actually the dilation carries up into almost into the proximal transverse arch as well. And the normal distal arch, no coarctation, and normal descending thoracic aorta. So this child has not yet made it to intervention, but I imagine intervention will be happening soon. So those are kind of the cases to demonstrate, hopefully, the principles that we've talked about today, which I think cross-sectional imaging, especially if you're thinking that your patient's aortic valve requires surgical treatment or some sort of treatment, cross-sectional imaging can be really helpful to understand the whole package, like from the subaortic area all the way around the arch to the descending aorta, and it can help determine the surgical indications, especially around those guidelines that I shared with you. We talked a little bit about MR and CT and the different indications, advantages, and use in workflows. And it's just that it's an important part of like comprehensive aortic assessment, and especially with more modern technology that we have now that I think is becoming widespread in many hospitals. It's pretty accessible to patients and really helps guide their appropriate treatment. thank you for your attention.